Hello, good morning, and good afternoon or good evening. It really is an incredible pleasure to come to Gulf Interventional Society Conference and bring you clinical insights from TCT and all that you need to know. My name is Roxana Mehran from Mount Sinai Hospital, and it really is an honor to be here. These are my disclosures. TCT 2023 was unbelievable, and it was quite a very busy meeting with lots of great science. We had 12 presentations of late-breaking clinical trials, and there were so many. But for this, I will try to give you a little bit on structural, a little bit on peripheral, and a little bit on coronary, what I think were the really hot topics. On the structural side, for the very first time, we started to see some long-term data of TAVR versus SAVR. There are increasing number of TAVR procedures, especially in the younger and lower risk patients. So understanding the very important issue of durability and longer term follow-up becomes tremendously important, especially since TAVR procedures are totally overtaking surgical aortic valve replacement. So we're seeing more and more SAVR decreasing at the ages of less than 65 and TAVR going up. And as you could see that very nicely here. So at TCT, we heard the PARTNER 3 study. This was symptomatic severe aortic stenosis in low-risk patients by the heart team, STS score less than 4%, one-to-one randomization of 1,000 patients of TAVR versus SAVR. And of course, the annual follow-up will go on to 10 years. The primary endpoint was at 1 year, but it is really important to note that we have to see these patients all the way through 10 years. What we saw at TCT 2023 were the 5-year data. And these are here, 1,000 patients, 5-year data available in 88.3% of the surgical patients and 94.6% of the TAVR patients, 92% of the patients available for that primary endpoint at 5 years. The primary endpoint of death from any cause, stroke or rehospitalization, again, trended to be better for TAVR versus SAVR. But as you could see, over time, there was a catch-up from TAVR up compared to surgery. Importantly, the stroke rates are similar between SAVR and TAVR in this low-risk population, and at 5 years, it's not small, and around 5 to 6%. Death from any cause trended to be a little bit lower in surgery, 8.2 versus TAVR at 10%, but no statistical significant difference. Rehospitalization, lower in TAVR compared to SAVR, but no difference, statistical difference. All of these endpoints are very similar. But we did have a second primary endpoint of looking at the win ratio, basically evaluating the wins between TAVR and SAVR. There are 225,000 patient pairs, and what you do is you could look at hierarchical components of all-cause mortality. As you could see here, that in the patient pairs, the wins for all-cause mortality, 8.4% higher than the wins in TAVR. So 8.4% for surgery, 6.9% for TAVR. On disabling stroke, however, the wins went to TAVR. On non-disabling strokes, the wins went to TAVR. On rehospitalization days, valve, procedure, plus or minus heart-related, the wins went to TAVR. And the total wins are in favor of TAVR at 22.1% versus 19%. But overall, the win ratio is similar, actually. So no difference between these two. And if you look at the conclusion, the 5-year follow-up findings from the New England Journal article from PARTNER 3 reaffirm the clinical benefits of SAPIEN 3 TAVR as a meaningful alternative to surgical therapy for low-risk, severe, symptomatic aortic stenosis patients. This is only with 5-year data, and we look to see these, obviously, for the 10-year data. Now, similarly, you need to know that the Evolute valve presented their 4-year data, and those data looked very, very good for TAVR, but we'll wait to see those 5-year data. Now, on the peripheral side, the infrapopliteal below the knee arterial disease have inherent limitations. We know this. And although bioresorbable scaffolds did not work in the patients in coronary as well, in the options, especially for tibial circulation, angioplasty, drug-coated balloon, atherectomy, drug-eluting stents, bare metal stents, but what about bioresorbable scaffolds? This is the investigational device that was evaluated, the Esprit BTK drug-eluting bioresorbable scaffold. It's a temporary scaffold that will resorb over time with a backbone comprised of 100% of poly-L-lactide, PLLA, and a strut thickness of 99 micromillimeters. The coating is the active pharmaceutical ingredient of everolimus-eluting everolimus and the biodegradable polymer, and there are 4 platinum markers of the same mass, 2 each embedded at the proximal and the distal ends of the scaffold. A very interesting device. This was used in the LIFE BTK multi-center trial. It was designed in 261 patients randomized 2-to-1 to evaluate the safety and the efficacy of the Esprit BTK DRS system compared to PTA for patients with infrapopliteal disease who also had critical limb ischemia. This obviously was very, very important. The patients were followed up very, very closely, up to 1 year, for the primary efficacy endpoint of limb salvage and primary patency, and important safety endpoints of freedom from major adverse limb events and POD. The data evaluation was at 12 months and was presented at TCT 2023 by Dr. Varco. The primary endpoint was met with an absolute risk reduction of 26.3%, significantly lower for the Esprit BTK system compared to PTA. This was over a period of 450 days time post-index procedure for the 1-year endpoint. The components are there, and as you can see, pretty much the binary restenosis being lower, the freedom from above ankle amputation, and 100% occlusion of the target vessel also lower, significantly lower, in favor of the BTK system. And pretty much, if you see, every single one of the endpoints worked beautifully for the Esprit BTK system. The safety was quite good, and there were no differences in safety whatsoever, and it was non-inferior to PTA. And I believe that this was a very, very important New England Journal presentation of this drug-eluting resorbable scaffold versus angioplasty for infrapopliteal arterial disease. Probably the best presentation there. Very, very exciting. Well, what about on the coronary side? There were many, many important trials there, but obviously the idea of where we had been, where we evolved from the era of thrombosis into a bleeding awareness era, and where we are today on the equipoise, and shortening duration of DAPT and looking at very important aspirin-free strategies, we were very proud to bring forth Twilight and Tycho, 2 studies that had been previously reported, one from South Korea, the other from across the globe, looking at the ticagrelor, aspirin ticagrelor for 3 months, and then ticagrelor monotherapy for the duration of the evaluation up to 12 months. And as you can do, we were able to do this through an IPD analysis. And this individual patient data was extremely great to have that kind of collaboration from our Korean colleagues. We were able to bring the ACS patients from Twilight, and then in Tycho, we excluded patients with major ischemic bleeding events after 3 months after PCI. The primary endpoint was looking at part 3 and 5 bleeding between 3 to 12 months. And the key secondary endpoint, which is the most important, was death, MI, or stroke between 3 and 12 months after PCI. What you could see, these are major bleeds, BARC 3 and 5, in patients with an acute coronary syndrome were reduced significantly, a very large reduction down to 0.8% going to ticagrelor monotherapy. And if you look at the very important endpoint of all-cause death, MI, and stroke, there were absolutely no differences. This very important subgroup analyses basically showed that very similarly in pretty much everywhere, bleeding was reduced and no increase whatsoever in death, MI, or stroke. So this publication showed us and reiterates the importance of, in ACS patients, of a ticagrelor monotherapy after a short period of open label aspirin ticagrelor. This was published by the first author, Dr. Baber, in Circulation. What about in-stent restenosis? Very, very important. Such an important issue for all of us. There are so many different mechanisms, but importantly, what we do know is that we can't continue putting stents inside stents over and over again, because once a patient has diffuse recurrent ISR, they really will end up coming back more and more. The agent drug-coated balloon, believe it or not available in our country, in the United States, was the paclitaxel-eluting balloon. No drug-coated balloon is for coronaries has been approved in the United States. But here, this FDA IDE, under the direction of Dr. Ye and Dr. Courtenay, looked at the paclitaxel-eluting balloon with a 2 micro per millimeter squared dosing of paclitaxel using a hydrophobic lipophilic crystals with rapid absorption and sustained retention on a balloon, have been evaluated in the agent IDE study design, which is a prospective randomized multi-center superiority trial across 40 US sites with 2-to-1 randomization of ISR lesions in native coronary vessels of lesion length less than 26 millimeters, reference vessel size of 2 to 4 millimeters with high diameter stenosis. Primary endpoint of target lesion failure. The patients were randomized in a 2-to-1 allocation with excellent follow-up. And here's what the target lesion failure showed. As you might have expected, the agent drug-coated balloon versus plain balloon angioplasty was significantly lower target lesion failure. And of course, this is extremely important to look at TLR and target vessel-related MI, and both reduced with the agent drug-coated balloon, showing us the residual events here, showing us that in-stent restenosis is not a benign disease. Definite and probable stent thrombosis was significantly lower, 3.9% versus 0 for the agent balloon. And you could see that this worked very, very well in non-diabetic patients. I think for diabetic patients, we still need some evaluation in larger numbers of patients. So no question, this was also accepted in the New England Journal of Medicine and published. So very, very excited about what we brought you at TCT, and we can't wait to have each and every one of you come and join us 2024, October 27th to 30th at the Walter E. Washington Convention Center in Washington, D.C. See you all there. Thank you so much for your attention.